My name is Jasper. I am a policy officer at the Belgian NGO Viva Salud, and I am a member of the working group Determinants of International Health. This working group is hosted by the two platforms, Because Health and the Action Platform for Health and Solidarity. Because Health is an informal and pluralistic platform that connects members from the academic world, NGOs, the Belgian Development Corporation, and partner organizations worldwide. The Action Platform for Health and Solidarity is an initiative of the biggest trade unions in Belgium and mutualities, and it aims to connect those actors with NGOs, health organizations, and other networks and associations, basically. Before we begin some technical announcements, we are surprised with the high number of people who registered for this webinar. We aimed to organize this session as a discussion, but we would like to ask you to mute your microphone so we don't have any background noises during the session. We will be having some time at the end of the session for Q&A. So please put your questions in the chat box, then we will ask them to the panelists later on in the session. There is one other technical announcement. We have two speakers from El Salvador who will be speaking in Spanish. So for those who want to follow the webinar in English, you will find a tab at the bottom of your screen, a globe where you can follow the webinar in English. So that will probably be for the last part of the presentation of the webinar. Now, this discussion is part of a series that we have set up with the working group in the past 6 months to touch on issues related to global health and the COVID-19 pandemic. We had a first session in November on food insecurity and a second session in January on access to vaccines. Today, we would like to focus on how development cooperation can contribute to strengthening health systems. Because today, a lot of the debates in global public health, of course, are understandably focusing on the COVID-19 pandemic. But what we want to do is we also want to look forward as well. The COVID-19 pandemic has laid bare a number of deep-seated inequalities, deep-seated problems with how our society is organized and the way our health systems have been set up. And so what we want to do during this discussion is also look forward and basically look how we can take those lessons from the pandemic forward, let's say. It is clear that many health systems were unprepared and unable to cope with a crisis of this magnitude. According to the WHO, 9 out of 10 countries, more than 1/3 of normal health services were disrupted. And we have seen that health workers have come under a lot of pressure, that there was a lack of protective equipment in many countries, and that basically health systems were unable to cope with this crisis or to deal with this crisis in an effective way. Now, despite all of this, we see that a lot of energy and a lot of attention is dedicated to solving this crisis with vaccines. The root causes of the pandemic get less attention, we have the impression. Barely 6% of the total contributions of the ACT Accelerator has been earmarked for strengthening national health systems, for example. And even before the pandemic, only 14% of health official development assistance went to strengthening national health systems. So that is why we want to look today at how development cooperation for health can contribute to strengthen health systems worldwide. And we'll be discussing these issues with a number of speakers, 5 wonderful speakers actually. First of all, we'll be hearing from Marco Angelo about how and if public-private partnerships can contribute to strengthening healthcare. Marco is a global health advocate at WEMOS, a Dutch organization, and he is the co-author of the report Risky Business, which is a position paper on the promotion of public-private partnerships in healthcare. And he will share the findings of this report with us and have a look at its recommendations. Then secondly, we have invited 2 speakers who will zoom in on the question of decolonization and aid. Ravi Ram is part of the People's Health Movement in Kenya and has worked on global public health. He is a co-host or part of the secretariat of the Kampala Initiative, and he will present the work of the Kampala Initiative on decolonizing health aid. Then secondly, Clara Affun-Adegbulu will discuss decoloniality in global public health. And Clara is a health systems researcher at the Institute of Tropical Medicine in Antwerp, and also a PhD student at the University of Antwerp. Then finally, we have two health activists from El Salvador who will share with us their work on how they aim to strengthen health systems in El Salvador as part of the National Health Forum, the FORO NACIONAL DE SALUD. And the forum brings together basic health organizations so that they can participate in the public health system. The member organizations of the forum work with local people to sensibilize and mobilize them for the right to health. Moisés García leads the health organization APSIS, and Isabel Montaya Duran coordinates community work with women and children and youth in 8 departments in El Salvador. They will be speaking in Spanish, so don't forget to turn on the translation at the end of the session. So welcome everyone. Marco, I invite you to the floor and let's hear from you. Thank you.
Thank you, Jasper. Good morning, good afternoon, good evening to everyone. Thank you for inviting me to present my work on public-private partnerships on healthcare. So let me share my slides. Can you see it?
Yeah, we can.
Okay. At WEMOS, WEMOS is a global health advocacy organization, and we work, I focus mainly on issues related to the financing of healthcare services. And as public-private partnerships are increasingly used to finance public services and healthcare services as well, we thought that we should do a work specifically on this topic at WEMOS. Sorry, I have some technical problems. Okay. So before we start to talk about PPPs, we should define exactly what a public-private partnership is and how it works. So a public-private partnership is basically a contract between a private actor and a government, whereby the private actor finances and provides a public service. For example, it builds a hospital or a school. But then the private actor is repaid for the service provided by the government or by the citizens through user fees or by a mix of both. So as you can see from the scheme, the ultimate people who pay for a PPP, a public service, then are the citizens and the government, which is basically the same thing. What differentiates really a PPP from a government procuring services from a private actor is basically that the private actor is also involved in the financing of the services. So it puts the initial capital. And this has very big consequences, and we will see why. But why are PPPs so important? Well, nowadays, first of all, we see how many governments, the spending ability of many governments is limited by a number of factors. IMF programs, economic treaties, austerity policies, a number of factors. And so where the government cannot invest, the private sector steps in and invests in in public services. But it's also a very specific policy that's promoted by international actors such as the World Bank. So the picture that you can see here is a picture from a document from the World Bank from 2017 that's called Maximizing Finance for Development. And basically, this document says that governments who want to finance a public service, they should first look at all ways of private financing or financing it in commercial terms before using a public investment. And this involves also measures to sort of attract and de-risk the private investment. And well, PPPs are certainly a way to do that. PPPs are also promoted with a very specific narrative, and they are sort of, advertised. The World Bank and other organizations who promote PPPs say that PPPs shift the investment risk from the public to the private sector, of course, because the private sector puts the initial investments instead of the public, but that they also leverage the expertise of the private sector. They are more efficient because it's the private sector, and a lot of other ways to promote them. So at WEMOS, we decided to not take all these sort of advertisement for granted, but we looked at the literature available on PPPs, and also by the assessments that were made by the World Bank and the International Monetary Fund and these international organizations that actually promote PPPs. And we found that there is actually not much evidence that says, well, there is actually no evidence that says that PPPs are in any way better than public financing and public provision of healthcare services. Actually, a report from the made for the European Commission in 2017 said that actually PPPs tend to perform much worse, especially when they are related to social services such as healthcare. But let's go more into the specifics of these, and let's see how private investments sort of affects the delivery of public services. So first of all, PPPs are more expensive for the governments and hence for their citizens, simply because to attract public investment, private investment, there must be a built-in profit margin for the investors. And this is, of course, especially relevant in low and middle income country settings where the investment risk is considered higher, so it requires higher profit margins. And there are a lot of reviews, academic reviews that say how PPPs are more expensive, especially in healthcare. The second reason is that the private investment influences priority setting. What does it mean? So basically, because private investors seek to maximize their return, they want to invest in areas that are more profitable rather than in the areas that are more needed. So this means a focus on big hospitals rather than small healthcare facilities that are distributed to around the whole territory of a country. It means more specialized and technologically intensive care rather than, for example, primary care or really basic services that are less expensive and hence less profitable. And this really changes the priority settings, and we see how especially in low and middle income country settings, we have a large part of the healthcare budget that goes into these very expensive projects, and basic primary care is depleted of its resources. And another problem is that PPPs require complex contracts, and because they are such large and expensive projects, the contracts required are very complex, and they often need to be renegotiated. Basically, the private company that is running the project, after a few years or less, says, well, this project is actually more expensive than what we anticipated, so we need to renegotiate the contract, and the cost escalates. And also because healthcare services are essential services, the government cannot really withdraw the service from the area, so it's kind of forced to renegotiate the contract. And the last reason is that they can affect the access to health services, especially for poor population. And this is because sometimes PPPs require user fees, as we saw at the beginning, but also because often the private investment and private facilities are into areas, concentrated into areas where middle or higher income population live, hence leaving the poorest areas behind. And by the way, I don't know if it was evident, but in the green box, I put some examples. I can share them after my presentations if you want, and I can also share my paper. So to conclude, we wrote some recommendation on public-private partnerships that are quite basic. So first of all, they shouldn't be promoted as the sort of ultimate solution for healthcare provisions. Government should avoid contracts that involve high levels of private finance or blended finance, but instead they should aim to increase the budget for public healthcare. And this seems a bit contradictory, because I said at the beginning that the starting point of doing a PPPs is because the government doesn't have money to invest, right? But at WEMOS, so we kind of propose a sort of what we call the public first approach. We took the private first approach that the World Bank produced, and we sort of inverted it. And we believe that governments, when they want to run a public service, they should first explore all the ways to finance it publicly, which includes reprioritization of the public purse, which includes increasing taxation in a progressive way, but also to raise the quantity and the quality of external aid to finance these services. I'm finishing here. Well, if you have any question, I can address them at the end. Thank you very much.
Thank you so much, Marco. I think, like you say, we can get back to you with questions at the end of the session. So this is also to all the participants a call to put your questions in the chat box if you have any. I think that what you have just laid out, Marco, is very important in the sense that not only at the multilateral level, but also at the national level, we see that in some countries, promotion of the private sector, be it in the form of public-private partnerships or otherwise, has been more common in the last couple of years. And this also relates to, of course, to how we look at development cooperation in a broader sense. What does it mean? What should be its objectives? And how should it be reaching its objectives? And I think that is also why today we have invited Ravi Ram from the KAMPALA Initiative and Clara from the Institute of Tropical Medicine in Antwerp to talk about this question of decolonization related to the development sector and then especially the development sector for health. So Ravi, I invite you to the floor and we'll we'll be checking out your presentation right now.
All right, thank you, Jasper. I hope you can see the presentation right now.
Yeah, perfect.
Okay, I'll just do a very brief introduction, and then Clara will take us through her analysis of decolonization and decoloniality, and then I'll come back and wrap up with what the Kampala Initiative is actually doing this year. So what is the Kampala Initiative? We are a civil society group focused on alternatives to what's been conventionally known as aid, and we are challenging that term. The focus is on cooperation and solidarity, and we're looking to go within and beyond aid, and taking on very much of a decoloniality lens. What we'll do today, as I talked about, is look at what is our work on decoloniality and how are we defining that. And with that very brief introduction, let me turn over to my colleague. And as soon as I can change slides as well. There we are. So Clara, do you want to take us forward?
Yes, I can start. I hope everyone can hear me. Yes?
Yes, very well.
Good, okay. Thank you for having us, Ravi and I. I will quickly go through the idea of why we need to decolonize global health. So just before starting, I think it's best to introduce the idea, many of us know this already, but to reintroduce the idea of what exactly is colonialism and what is coloniality. So as most of us will know, colonialism is the universalization of a provincial ensemble of Western Eurocentric values, institutions, economic systems, and social relations. And this means taking this ways of being and ways of doing and taking them to other places that are not European. Of course, this then leads to a transformation, in some cases annihilation or even replacement of those cultures or those ways of being that have had to be transformed by the fact that the European ways of being have been taken there. And of course, this was something that happened during colonialism, but it's something that continues to happen in a process that we call coloniality, because they're discursive practices, they're frames of thinking that continue to reinforce and sustain this worldview. Next slide, please. Thank you. But so that's just a general overview. The question then is, how does this impact on global health? I will start by very briefly going over this using the social determinants of health framework that we all know, and just talk about three main areas where we can see the impact of colonialism in the past and coloniality on global health. One is, for instance, the determinants of health and health inequities. For instance, we can see how the capitalist worldview, the capitalist economic worldview that continues and which is part of the Eurocentric worldview, we see how that continues to affect political and socioeconomic realities. And this has direct impacts on things like the health system. For instance, when we think of the movement of health workers from low and middle income countries to the global north where the incomes are higher. We see it also on the impact on people's material circumstances, in the jobs that they're able to have, in the conditions they're able to live in the ways that they're able to finance their access to healthcare, for instance. Next slide, please. Thank you. Another big area where we can see the impact of colonialism and coloniality on global health is the hierarchization of people and cultures. When we think about this, there's often a tendency to think of the hierarchies in terms of people in the global north versus people in the global south. But it goes beyond that. It goes to things like racism. It goes to things like sexism, heterosexism rather, so in terms of sexual orientation. But it also goes to things like gender, so that one gender is perceived as being important than others. It also, beyond that, goes to the context of ability. So people who are seen to be non-disabled, are seen to be more productive, can contribute more, and are therefore ranked higher than others. And this has direct impact, for instance, on diversity and representation in global health institutions, and of course, on global health governance. For instance, there's a focus on health security in protecting Western states or countries in the global north from being affected by LMIC-generated diseases, rather than looking at global health security as something that should be done to protect the entire world. Next slide, please. Thank you. And finally, the third area that I wanted to touch on was the hegemony of ideas. So for instance, this affects things like the way we practice public health, the knowledge that we think is valid and valuable in public health, the knowledge that we discard, which leads, of course, to epistemicide, and the ways that we reproduce and produce knowledge. Next slide, please. So having said all of this, I think it's pretty clear why we need to decolonize global health, but just in case, I would like to reiterate just a few points. The first reason is because of solidarity. As long as none of us is, one of us is not free, none of us are. We can see this already with things like the ongoing COVID-19 pandemic, with the nationalism and the COVID and the vaccine, everyone protecting their own people, protecting their own countries. We see what is happening, and we see how that is leading, for instance, to the development of new strains and new varieties of the virus, which means that we can continue to be in this cycle of infection and reinfection and transmission and migration. So effectively, as long as one of us is not protected, none of us are. The second thing, the second reason why we need to decolonize global health is because it is the just thing to do. It is the right thing to do. When we think about the world that we currently live in, the current system that we have only serves very few people, even in the global north. It doesn't serve people who are disabled. It doesn't serve women and other genders. It doesn't serve non-heterosexual people. It serves a very small part of the community, even in the global north, not to talk of when we widen it and we consider the whole world. And the third reason is, of course, self-interest. We might laugh and say, you know, this is a bit of a silly reason, but it's an important reason. And the fact is, if we center European ways of being and doing things, and we discard other ways of being and doing things, we can, for instance, we might find ourselves in a place where we discard indigenous knowledges, indigenous ways of doing things, which are really important to the complex challenges that we're currently facing. Next slide, please. Thank you. So how do we decolonize global health? There are many, many answers to that, but I picked a few that I thought would be good starting points, shall we say. The first one is to recognize that global health is not just there. We have health inequities in our own backyards. We have people who are vulnerable, who are marginalized in our own backyards. Global health is not going somewhere in Africa, in Asia, in Latin America. No, global health starts at home. It means that we need to be humble and realize that we need to start from our own backyards. The second way we can decolonize global health is by recognizing that complex problems that we have, problems linked to migration, problems that link to infectious disease outbreaks, problems linked to climate change, all these are complex problems that require global and local action, and also pluriversal solutions. That is, not one solution that is copied and pasted for all countries across the world. Another way that we can ensure that we work towards decolonizing global health is by simply being humble, as I said before, and realizing that we don't know everything. And because we don't know everything, diversity and representation are important. I can only talk about what I know. I can only see things from my perspective. If there are more people across the table, we are more likely to come to solutions that are more effective. Next slide, please. Thank you. And finally, the thing is we need to put our money where our mouth is. And this is both at the institutional level and at the individual level. For instance, there's a tendency to focus on what I can do at my level. I can make sure that I involve other partners equally in collaborations. Yes, this is of course very important. But beyond that, we also need to advocate with our governments, advocate with people that we have access to ensure that global conditions are more equity promoting. Next slide, please. Thank you. So I will hand over now to Ravi to continue.
Thanks so much, Clara. Really good. I'm going to pick things up from where Clara had left those questions. How do we decolonize global health, and specifically development assistance for health, or aid? So we talked a little bit at the very beginning about what is the Kampala Initiative, and just a little bit more. We are a democratic civil society space for critical thinking activists and organizations around the world, recognizing we come from broadly the global south or the global north, but working together. When we come together, we don't just take the critique of aid, but we build on it. And we're looking to see how can we create what we call political traction for an alternative way of looking at development assistance. It's not that we don't believe that the world needs to ignore the problems. It's that we believe that a different model is not only possible, but necessary, and perhaps coming into being. And that's why we look at cooperation and solidarity beyond aid. Our founding document is the Kampala Declaration. And you can see the link at the very bottom there. We'll make sure that that pops up in the chat for you as well, in case you'd like to take a look at it. The Kampala Declaration is basically, it's our way of thinking about how is global aid or health aid defined by its colonial legacy. Clara was talking about how it's how the difference between colonization or coloniality, and we know that at one time there was discussion, it was a very legitimate discussion in the powerful capitals of the world about colonial medicine. And then I think that captured what still exists now. There is that power dynamic. Some people make the decisions, some people have the resources, and they tell other people what to do. Clara talked about health security and that self-interested aspect. That's very much part of even live current debates, not just during the COVID pandemic, but even prior to that. So much funding for public health is now framed as health security. From colonial medicine, we move to tropical medicine, and that term still survives in some preeminent institutions, not just in colonial powers, but around the world. And from there, we move to international health. Now there's an attempt at global health. These attempts at language, or changing the language, in some ways they mask the problem, in some ways they do represent progress. I think we have to take some of what Clara highlighted as the challenges in defining how to do things. We don't own it all. But I do encourage you to take a look at the Kampala Declaration a little bit further. Like I say, it's our diagnosis about where health aid comes from and how we might move beyond it. So what does decolonizing health aid mean for us in the Kampala Initiative? We've got several topics that we're working on, and you can see 3 of them bulleted right here. We want to see how much is aid not just solving a health issue, but it's actually a Band-Aid. It's there to make sure that the world is not suffering so much that we get revolutions and overthrow of the system. And if that's the case, then we need to see how can we move beyond that, so that it's not simply a stabilizing factor for inequalities that persist in the world due to a legacy of colonialism, but what can we do so that we are actually rebalancing the world so that all people everywhere have the opportunities to grow, thrive, and be healthy. Then we have to look at the aid system itself. It's not just that it's serving a larger purpose that's maybe reinforcing inequities, it's also inequitable in its own. And so part of our critique is to see not just can we analyze the colonial roots of aid, but can we also see what's inside the critique of aid that we can then change. And finally, then being very solution oriented, not just looking at the analysis and critiques, but how can we move forward? You can see a few screenshots of some of the presentations that or the webinars that we've hosted. It's been about 18 webinars so far in our 18 months. And we do have some solutions. You can see a few of them captioned here, and I'll encourage you to go to our website and take a look at more. So what actually do we do? Talked about the webinars already, and you can see there's opportunities. If you have ideas for a webinar, click into the website and make a proposal to us. We're happy to hear much more. And quite honestly, I would say more than half of the webinars that we have hosted have not come from our team. They've come from other people who want to use this space to test ideas and to see what makes sense. So again, that gets to Clara's point that we have to be humble about things. We have a mailing list, and that's more for sharing information. We're very open also to moderated discussions, and we hope to see that grow. We have several thematic working groups. Looking at the last one on PPPs, Marco, in his first presentation, was very much about that, and one of our more recent webinars was about the PPPs, and it was a case where WEMOS was able to come forward and test some of their ideas, along with our working group lead, who's actually in the webinar right now. That's Dennis Buchanan. Watch the Gap. That's the Global Action Program. It's a consortium of all the big heavyweights in global health aid, the big donors. And how are they coming together? And then who's going to watch them? Who's going to hold them accountable and potentially exert a little bit of influence? We have a group that's doing that. And together with WEMOS, we put out some publications. And then the Track Changing Initiative. That's coming to the point about language, and I've already talked about the term global health and where it came from. There's so much more that's embedded in terms of how do we define poverty? How do we talk about global health inequities? And how have we been trained mentally to think in colonial terms? And it's not that we want to, it comes naturally because it's all around us. And many of these big global international do-good NGOs will revert to very colonial language to raise money. We need to see how that can change. And so we're part of that as well. Looking forward, we very much want to have a 2021 milestone event. We only founded the Kampala Initiative in 2019. So in just a year and a half or more, we've done quite a lot. We want to see, can we have a milestone event even with COVID? So be watchful for that. And if you see Dennis Buchanan on the screen, message him. I think he can give you some ideas. And then you can see another workshop, maybe doing some country level work, some programs, more. Get to the website, you can see our work plan, and you can see what we did last year. So I'll wrap up with that. We're very much looking to a virtual debate because that's the world we live in at the moment. And at some point, it'll be fantastic if we can host different events in person around the world. But thanks very much, and back to you, Jasper.
Thank you, Ravi, and thank you, Clara. Thanks so much for this powerful and also hopeful presentation, I must say. Like one of the points that the both of you mentioned actually is the critical role of civil society, or at least trying to start to build a movement that can change things. And I have noticed that in the chat box as well, a small discussion was going on between Marco and one of the participants on what strategies that we should be applying to actually change things. Should advocacy be our main focus, or should we be organizing communities and so on? And that is, I mentioned this because that is where I want to go with our next speakers, next presenters, who will be talking about what role we social movements should be playing in strengthening health systems, and how we can mobilize communities into better access for healthcare. So Moisés, I pass the floor to you. I hope you, so just one more point for everyone, you can switch to Spanish, to English now on the translation at the bottom of your screen if you don't understand Spanish. Thank you, Moisés.
Muy bien, buen día para todas y todos. Vamos a abordar ahora una experiencia que desde El Salvador hemos estado trabajando durante ya muchos años. Ustedes saben, El Salvador es un país en Centroamérica que durante las últimas décadas del siglo pasado estuvo inmerso en un proceso de guerra que pues generó muchas situaciones. Una de ellas fue que muchas comunidades, muchos lugares en el país fueran abandonados por el Estado por la misma situación de guerra. El Estado debía designar muchos recursos para atender esa situación y además se alejaron de los territorios, permitiendo que en estos lugares la gente tuviera que organizar sus propios sistemas sanitarios para atender tanto la situación, las enfermedades producto de las condiciones del entorno, pero también todas las situaciones que se originaban por la represión y por la misma guerra. Entonces, parte de por ahí la historia de cómo se organizan y cómo nacen muchos movimientos y organizaciones que trabajan. Compartir con ustedes el papel de los movimientos sociales que recoge una parte de la historia posterior a la guerra y que inicia ya en el periodo de los acuerdos de paz que se firmaron acá en el país. Y entonces ahí hay otras luchas por ir construyendo una salud de otra manera, una salud en donde el Estado pueda tener un papel más importante. Entonces Isabel va a compartir un poco sobre cómo esas organizaciones de base han participado y han logrado llegar a entablar alguna negociación y escuchar su voz y poner sus puntos en la agenda pública. Entonces les dejo con Isabel.
Buen día. ¿Sí? ¿Se escucha? Sí. Sí. Bueno, quizá iniciaríamos contando un poco, ¿verdad?, de la experiencia de las organizaciones sociales acá en El Salvador, quienes conformamos en el 2001, ¿verdad?, una alianza contra la privatización de la salud. Estas organizaciones sociales, ¿verdad?, organizaciones que, como decía el compañero Moisés, nacen desde el proceso de acuerdos de paz, ¿verdad? Nos reunimos para poder hacerle frente quizá a las situaciones de desigualdad que existían en ese momento, ¿verdad?, sobre procesos del tema de salud como tal. Pero también la experiencia, ¿verdad?, organizativa que cada una de estas instituciones, ¿verdad?, tenemos en nuestro quehacer. Partiendo de la experiencia de la Alianza Ciudadana, se conforma una expresión territorial, ¿verdad?, al cual denominamos Foro Nacional de Salud, que se constituye a la entrada del gobierno de izquierda, que es Mauricio Funes, ¿verdad? Iniciamos con la organización territorial, ¿verdad?, a partir del 2009, pero se crea esa expresión ya directamente desde la participación del liderazgo comunitario en el 2010. El Foro Nacional de Salud, pues es una expresión territorial, ¿verdad?, que incide o influye desde los territorios y en diferentes niveles en el tema de salud comunitaria, de salud de la población, de la salud a nivel nacional. Creo que lo importante, ¿verdad?, de rescatar del foro es la participación vinculante que se tiene con diferentes actores clave dentro del Sistema Nacional de Salud. En el proceso de creación, ¿verdad?, para nosotros como organizaciones de base, la participación en las políticas, en la política sanitaria de salud es muy importante, ¿verdad? Este proceso de participación desde la creación o construcción de políticas públicas. En ese sentido, el Foro Nacional de Salud, desde sus liderazgos, ha participado en la política nacional, ¿verdad? Para lo cual ha sido necesario fortalecer a las comunidades, ¿verdad? Desde la organización, desde el enfoque de sus derechos, de la defensa de sus derechos. En el 2009, ¿verdad? Se inicia o se entabla una comunicación, ¿verdad? Con el gobierno de izquierda entrante, que fue Mauricio Funes. En ese sentido, el Foro Nacional de Salud y la Alianza Ciudadana contra la Privatización de la Salud genera un espacio, ¿verdad? De relación o de participación activa dentro de lo que es el sistema de salud, ¿verdad? Pero con una participación real, con una participación activa, participando en lo que es la construcción de la Política Nacional de Salud. En ese momento se fue llamada desde el 2009 al 2014 que se creó la política llamada Construyendo la Esperanza, ¿verdad? En esa política, en la construcción, participan las instituciones que formamos parte de la alianza, pero también participa el liderazgo de nuestras comunidades. Y luego, pues, se ve necesario, ¿verdad?, contar con el fortalecimiento en las comunidades para generar que fuera mucho más analítica, mucho más efectivas en su participación. Y es así como en 2014 al 2019 se crea otro instrumento, ¿verdad?, que es la construcción de la estrategia de la Reforma Nacional de Salud. En la Reforma Nacional de Salud se contaron con 8 ejes a su inicio, ¿verdad?, que tenía que ver con la participación de todo el sistema de salud, pero lo importante o inédito en este periodo fue la participación ciudadana, ¿verdad?, desde uno de los ejes de la reforma, lo cual fue como una participación efectiva, ¿verdad? Y desde las comunidades, como la exigencia de estar en la construcción no solamente de las políticas, sino también de todo el quehacer en el sistema de salud. Una participación efectiva que llevara a las comunidades a poder ser parte de la construcción de la salud dentro de las comunidades. El aporte que podrían dar las comunidades al sistema como tal, desde la participación en las redes integrales e integradas de salud, ¿verdad? Cómo los liderazgos comunitarios pudieron en este caso hacer efectivo el ingreso de esta participación dentro de las unidades comunitarias, dentro de los hospitales, dentro del sistema nacional como tal, ¿verdad? En diferentes espacios.
Solo queda un minuto.
¿Cuánto? Quizá me estoy extendiendo demasiado. Algo importante, ¿verdad?, sobre las propuestas del Foro Nacional de Salud o del movimiento como tal, ha sido la participación efectiva en la construcción de no menos de 15 políticas públicas. En este caso, la política de salud sexual, salud reproductiva, la política de lactancia materna, la política nacional ambiental, ¿verdad? Así también como la participación en la construcción de instrumentos técnicos jurídicos dentro del Ministerio de Salud.
Ahí está. La contribución.
A ver. Y en cuanto a la contribución, perdón, ¿verdad? O los aportes que como foro, ¿verdad? se ha tenido dentro de El Salvador, es los conocimientos, ¿verdad? Que las comunidades aportan dentro de sus diferentes espacios para poder promover lo que es la salud, ¿verdad? Con el Ministerio de Salud se proponen soluciones a las necesidades específicas de la población y a poder atender las diferentes situaciones de manera diferente a cada grupo, ¿verdad? Con los que se trabaja, promoviendo salud, ¿verdad? Desde las determinantes, ¿verdad? Desde cómo las comunidades pueden hacer un análisis de qué determina que se enfermen dentro de su entorno, pero no quedarse hasta ahí, ¿verdad? Sino que le ayuda a comprender que la salud puede generarse dentro de las comunidades, siempre y cuando éstas pues cuenten con todas las condiciones necesarias, ¿verdad? Hacer un análisis de la situación, de las inequidades, de la desigualdad que existe dentro de las comunidades, de todo lo que habló la persona que nos antecedió, ¿verdad? Que hay que tener en cuenta y tomar en cuenta las determinantes sociales de la salud. En el caso del Foro Nacional de Salud, su enfoque pues es el de determinación social de la salud y los derechos de la población como tal, ¿verdad? Creo que el abordaje de las enfermedades debe de verse de manera integral, desde la solidaridad, desde ver la parte de la soberanía, ¿verdad? El pueblo como soberano, no podemos tener, no podemos ver la determinación social de la salud si las comunidades están reprimidas. Y otra parte importante en la del Foro Nacional de Salud es la participación, ¿verdad? Como un derecho que dinamiza los derechos de la población. Y es ejerciendo la parte de auditoría social, ¿verdad? Para nosotros verificar el cumplimiento en las políticas públicas, el poder controlar la asignación de los presupuestos, ¿verdad? Para la población, el adecuado uso de todos los recursos asignados, pero también en la parte de exigencia, ¿verdad? Del cumplimiento de estos derechos. Creo que es importante la contribución que el foro ha tenido en estos espacios y ante todo a nivel nacional, ¿verdad? Los logros que se han tenido con la participación ciudadana. Otro de los elementos que nosotros consideramos importante es la contribución para la verificación de la calidad en la atención y cómo desde la participación vinculante de los y las lideresas del Foro Nacional de Salud se ha logrado mucho dentro de del sistema de salud, la parte de humanización de esos servicios. No sé en otros países, pero acá el maltrato, ¿verdad? Ha sido sistemático para las poblaciones más vulneradas. No así para las personas que tienen mucho dinero, ¿verdad? Sino que más bien para las personas de las unidades, de las comunidades rurales, las zonas urbano marginales, ¿verdad? Y toda esa situación de desventaja que viven nuestras comunidades. En este sentido, la sociedad civil organizada ha jugado un papel importantísimo dentro del país, ¿verdad? Logrando así que se pudiera aumentar en estos periodos el presupuesto, ¿verdad? De salud en El Salvador. Voy a dejar al compañero Moisés porque él continúa.
Bueno, en este proceso, ¿por qué es importante un sistema público de salud? Nosotros hemos identificado en todo este periodo y con todo lo que se ha venido trabajando que sirve para garantizar el derecho a la salud y a la vida de la población en condiciones de igualdad de acceso sin discriminación por razón de sexo, género, condición social, religión o política, y que en El Salvador ha habido mucha dificultad para poder ir avanzando en esto y ha habido que ir transformando este sistema. Pero lo importante también del sistema público es que más allá de atender las enfermedades, el sistema debe considerar la promoción de la salud, debe generar información adecuada y oportuna que sirva para construir propuestas de políticas públicas que garanticen la salud de la población. Es un tema de balance entre desarrollo y salud. Nuestros países han sido históricamente servido para extraer los bienes naturales y eso ha generado graves condiciones en el territorio. Pero además se deben de disponer de tecnologías adecuadas para la recuperación de la salud de la población y se debe garantizar también personal idóneo para que haga ese trabajo. Y eso solamente lo puede hacer un sistema público porque un sistema privado buscará generar ganancias antes que garantizar la salud y la vida de la población. Y en relación a los aportes que la cooperación ha realizado, desde nuestra experiencia, ha facilitado condiciones para articular entre organizaciones sociales y espacios de participación social. Y eso fortalece la capacidad que tiene la sociedad civil de realizar propuestas. Nos ha servido mucho también para vincular el apoyo técnico que potencia las capacidades de las organizaciones y las comunidades para participar activamente. Permite potenciar las coincidencias temáticas y la articulación de agendas. Y eso nos permite también realizar propuestas ante los actores públicos que dicen, según su visión, que solamente ellos tienen la capacidad de hacer esa propuesta. Sin embargo, lo hemos demostrado que desde la sociedad organizada e informada se puede también proponer. Facilita intercambios de experiencias entre espacios afines, locales y regionales, y eso también nos sirve para ir tomando las experiencias de otros países y de otros actores que también han ido avanzando en este proceso. Pero también la cooperación internacional apoya para visibilizar a nivel internacional y en espacios regionales las problemáticas locales, sobre todo de violación a derechos humanos. Creo que este espacio también es un ejemplo de eso. Nos damos cuenta cómo otras y otros están trabajando también por garantizar el derecho a la salud de la población. Bueno, gracias. Nos quedamos por ahí.
Thank you very much, Moisés. I think you very well laid out the issues at stake. Now, just one more question to the participants. If you have questions for the panelists, please put them in the chat box so we can ask them to our speakers. Now, I already have one question in the chat box for Ravi and Clara from FOS. One first question is, how do you integrate the culture and well-being of the people and the teams with timing and funding that comes from countries of the global north looking for rapid results? So I guess that she talks about the tension that exists between realities on the ground and expectations and objectives that come from the global north, where the funding very often comes from. I don't know, Ravi or Clara, if you already want to respond.
I'll say a few words. Clara, do you want to say something as well?
Yes, I can say a few words.
You go first, then I'll come in.
Okay, so I think it's quite difficult, but it's not something that cannot be done. I think that if we work more closely with the people, maybe the funding is something that will not be so easy to change, because at the end of the day, we still depend on funding from governments, from our governments, etc. But from that perspective, we can lobby with our governments and advocate with them. And then when it comes to the local level and ensuring that people's well-being is taken into account, then it's about working with the people that know the context, rather than just trying to do things by ourselves. Ravi?
Sure, yeah. I'll just add on that a lot of what we're looking for is that decisions and power don't rest with the donor. We know that we have an imbalance of resources around the world, and we'd like to see that we can not let decisions be driven by that imbalance and see if we can get another way of doing things. I'll highlight just a few examples. We in the Kampala Initiative don't own these, they don't come from us, but we are happy to host them. There is the National Health Advocacy Fund. It's actually being pioneered by a group, I forget the group's name, but it's actually through the Netherlands. and they're looking to see how can they fund advocacy efforts in countries that are not dependent on international NGOs for support, so that we can have ground up. That will get to your point about understanding the culture, the context of the people and the teams who are working. Specifically around mental health, several of my colleagues here in Kenya have done much more work in that, and I don't want to take away anything, because if I say something, it's my own guesswork. I hope that's helpful, though.
Thanks, Ravi and Clara. I think I would like to come back on the small discussion that Claudio and Marco had in the chat box. Marco, if you could shortly explain the work that you've been doing regarding this paper and your recommendations. You mentioned that you published an open letter to the World Bank. If you could talk a little bit about why you did that and what exactly it is that you aim to achieve.
Sure. Thanks. So, of course, we are an advocacy organization. So any type of research that we do must be connected to an advocacy towards all the actors that influence public healthcare. And as the World Bank is the main promoter, main supporter of public-private partnerships, also in healthcare, we decided that just publishing a paper wasn't enough, and we accompanied the publication of the paper with an open letter that addressed the World Bank. We also collected signatures to support our claims. The letter was co-signed by 93 organizations, and we received a response from the World Bank. We have been in a couple of calls with the World Bank staff on the topic, and we are actually aware that right now public-private partnerships in social services are quite criticized within the World Bank. Now, this is, of course, is not just our little open letter that did that. It's the result of years of advocacy and research from many civil society organizations, many networks. For example, all the work that has been done by Eurodad and Maria Jose Romero also really contributed to that. Yeah, of course, the World Bank is the World Bank, and it has a very specific approach when it comes in a very specific view of the private sector and privatization. What I want to highlight is that the advocacy and the work of civil societies is also is very important to challenge this mainstream narrative that there is around privatization and healthcare. Yeah.
Thanks, Marco. And this, of course, brings up the question that I think sometimes we see in the debates on decolonization. You have a current that basically advocates for just getting rid of the institutions that are part of the current global system, even sometimes advocating for getting rid of the development cooperation as such, and start to build new systems and new relationships with across different countries and across different regions of the world. So I would like to ask to Ravi, maybe, because I think that this is a point that you could comment on. If you could add something on this point, and talk about what would be your view on this issue? Should we try and reform the current institutions that we have, or should we rather go and build our own institutions from the ground up? And as you say, and you mentioned the example just now, with organizations that work from the ground up.
Just some quick thoughts. In an ideal world, yes, we could design the institutions that we want that would actually serve people on the planet and not simply profits, which gets to the kind of things that Marco talked about, as well as Isabella and Moisés. But we don't live in an ideal world. So we struggle with how much do we want to work toward reforms, knowing that sometimes the reform is just a compromise. And if we're compromising our values, that's even harder for us. I mentioned the National Health Advocacy Fund in an earlier comment. I think it's worth exploring. I think it also has some challenges there. I wouldn't necessarily say that that is the way to go, but as a way forward, absolutely, because it's experimenting with a different model of sharing resources and bringing up voices for institutions and people who don't have access to those resources. Another example, actually, this one comes from, it's the Yep Lung Institute, and the name of the person is escaping me, I'm sorry, but it's talking about global public investments. From the start of the name, I have a gut sense that this is wrong, because as much as global public may start in the right steps, investments in public services doesn't make sense. From my point of view, I know Marco, you and I have had these discussions. An investment demands a return, and no matter how much is the financial world talks about their social returns, their environmental returns, in the end, if we're using the language of an investment model, then we get trapped into that model. I think we should I like the alternative is global public goods. I think that's also evolving. But the point is, getting to your question, Jasper, and where we are in the discussion, I'm willing to let this global public investment proceed, and we did give it space early on in the Kampala initiative, so that we can see how can we shape the thinking that's going into a new program. We know that their intent is good, but we don't necessarily agree with everything that they're putting forward. So it's, again, making the compromise to see how can we take steps forward without losing what the ideals and the vision that we do have for the world. That's what we've been doing in the Kampala initiative. So it's really not just lingering on the critiques, we're developing those critiques further, but trying to experiment and see what really works and also what doesn't work. In the event that the two experiments that I mentioned or any others, if they don't work out, then we would want to call attention to that and examine why. And same thing with, I'm a big fan of Marcos's inverted pyramid, or the cascade, where he turned what the World Bank has and he turned it upside down. I think that's fantastic. Is it perfect? No, but it's a huge step forward. And I think I'm so pleased that he and Barbara and others at WEMOS have put that forward so that we in civil society can then build on that. And that's what it means to have an alternative narrative. Clara, I think that you also had a few points over there. I don't want to take away from the ideas that you can put forward.
No, it's fine. I think you've said mostly more practical version of what I would have had to say.
Marco, I see that you would like to react.
Yeah, no, well, thank you, Ravi, for your kind words. I wanted to highlight that I think Claudio wanted to reply to my comment. I don't know, Claudio, if you're still there, or you still want to add anything?
Thank you very much. I think the question that was raised to Ravi and the question I raised to Marco are related. They are related particularly in the sense that the whole crux of the problem is the power balance, and the power that these institutions have and the power that we do not have. So the idea is, if we concentrate more in helping create counterpower so that we get to a point where we can eventually influence these institutions that are colonizing our minds, we probably would have more mileage in the long run. And this is what the human rights-based approach basically brings in. We are not begging anymore. We are demanding, and claim holders organized and mobilized have to begin looking at what they are entitled to from the existing international human rights law and began bitching and begin protesting and going to the streets. And we have many examples in the world right now of groups going to the street to demand changes. So it's extremely important. There's nothing wrong with looking at alternative models. We can come up with beautiful alternative models, but if we don't have the power to make the changes, they are going to stay as beautiful models. And that's what I think we unfortunately spend a lot of time thinking that we can change the system. I just want to ask all of you in this webinar today, number one, how many declarations and letters have all of us signed in the last 10 years, depending on how long you have been in this business? I have been in this business for more than 25 years. And how much follow-up we do if these letters and declarations are doing any change, and how much hours of work we spent writing the right language to have these declarations right and sending them to the right addressees, and nothing much really happens. That's the real problem. So basically, we have to spend more time going to work at the grassroots. And that is where the example from El Salvador is so relevant. And in the chat, it was also mentioned that the Guatemala work is very important. I think that's where most of our priorities are, because we are not at the point where we have created a type of counterbalance that even tries or will even succeed in changing the World Bank. That's not where the things are going to happen. Yes, in the World Bank, there are people with good intentions. Yes, there are people somehow who came from our public interest civil societies and then were hired by the bank. But the decisions are made in the boardroom, not by these technical people who have their heart in the right position. And who is in the boardroom? Primarily the countries who have most capital investment. And who are those? If you look at the board of directors of the World Bank, their answer is there. Same thing with the Monetary Fund. Same thing with Davos. We are not going to change these institutions from above or by writing letters or declarations. That's not going to list us anyway. Okay, that's what I would say for now.
Thank you, Claudio. Clara, would you like to react? I see that you have your hand up.
Yes, I just wanted to add to what Claudio was saying, that there is a momentum at the moment with the fight for social justice. But I think in our push for this, I think it's just important also to remember that decolonization is, at least from the perspective of what Ravi and I talked about, it's not just about switching the power dynamics. It's also about switching the culture that we have, the economic system that we have, which ascribes a level of value to productivity and discards people that are not deemed to be productive. I think it's very important to keep that in mind. So it's not just about switching the power dynamics so that the South becomes as powerful or more powerful without switching the fundamental cultures that our worldview is based on at the moment.
Thank you, Clara and Claudia, for those comments. I would like to end the discussion now. I don't know if anybody would like to have a final comment. If not, then I would like to thank everybody to join this discussion. I think it was a very interesting one. Thank you also to our speakers, the panelists, and of course to the translators. We will provide you with the presentations of the speakers, and more documentation, so you can have a look at the paper of WEMOS, for example, or the work of the Kampala Initiative. Thank you so much for being here, and I wish you a very good afternoon, morning, evening, wherever you are. All right, thank you. Bye-bye.
Thank you. Bye.